Good afternoon. I will present to you a course about the urinary tract and how imaging can answer to the most common question. As you might know, imaging the urinary tract is a large part of the workload of a pediatric imaging department, and what we want to is to diagnose as early and as accurate as possible the correct diagnosis. We want to prevent complication, and we want to ascertain the follow-up. All type of imaging technique are involved. We will see it according to the ALARA principle. We might have to take more and more into account health economics. If you are really interested by this topic, I suggest you to get on the espr.org website to get the recommendation of our Radiology working group. So what are our objectives? We want to learn about imaging protocols. We want to be able to recognize the most frequent congenital malformation, and we want to gain an understanding in diagnostic imaging approach of the urinary tract infection. What are the techniques? There are various, there are many, and the first main message of this course is surely, as you can imagine, ultrasound. There are different types of ultrasound that we can use. Ultrasound should be the frontline examination in children. It's the best screening technique to look for urinary tract dilatation, lithiasis, and diffuse parenchymal disease. It should be performed with high-resolution transducers fitted to patient's age and size. Both kidney and the bladder should be analyzed. You should use the decubitus and position. And when you analyze the images, you should measure the kidney, look at the echogenicity of the cortex and medulla, look at the corticomedullary differentiation, and to the presence of calcification and cyst. The use of Doppler should be encouraged, but it's more difficult in infants. The main characteristic of children kidneys is the corticomedullary differentiation. We can see it already in the fetus, we see it surely in the newborn, and sometime in the child, and this is related to the hyperechogenicity of the cortex with hypoechoic pyramids. So especially in the newborn, it should always be present. If you want, you can measure the corticomedullary ratio, the thickness of the cortex, divided by the thickness of the medulla, and it is around 0.38. This is a fetus seen in his sagittal scan. You can see the black area, which is bladder. You can see the kidney, and you can see hypoechoic medulla and hyperechoic cortex leading to the corticomedullary differentiation. Above, you can see two newborns, again, massive corticomedullary differentiation, hypoechoic medulla. In the lower part, you can see older child. You can see a mild corticomedullary differentiation. This will depend on his sickness and age. Do we use Doppler? Sure, we should use Doppler to see renal vessels, but as I mentioned already, it might be difficult to use in small children. The renal vasculature is well known, and particularly interesting are the arcuate vessels that determine the limit between the cortex and the medulla. They would appear on standard ultrasound as echogenic line that you can see in the lower middle of the slide, and it highlights on a color Doppler. The pyramids are vascularized, but through very tiny vessels, and this is at present time not demonstrated by color or pore Doppler. There are different types of ultrasound that could be used. Harmonic imaging in thicker, obese children, contrast imaging can be used, but you should be aware that this is not allowed in children in many countries. And there can be, you can use 3D and 4D ultrasound, but at present time this is more of research than in daily clinic use. And probably in the next future we would use elastography, especially in renal grafts. The second leading technique in pediatric imaging are cystographies. There are various types of cystographies. There is the most common classical radiological voiding cystourethropy. It's the best method to detect reflux, to visualize the bladder and the urethra, but you can also use cystosonography and isotopic sonography. Radiological sonography is able to provide information on the presence of reflux. On the left side you see even intrarenal reflux. You can grade reflux, and surely you can see the urethra, especially in a patient with a micturition problem. You can verify before and after treatment. Some teams have developed the use of cystosonography with a contrast material instilled into the bladder, but as mentioned, this cannot be used in every country. The images provided are really impressive. You can see reflux on the left side and the normal urethra on the right side. The third technique that used to be the leading technique in imaging uropathies, intravenous urography, has very few indications left. If performed, it should be limited to 1 or 2 SCOT views. Our working group on uroradiology has published procedural recommendation that I would not detail, that you can find on the website of the ESPR, as how to perform and what to obtain in IVU in children. Fourth technique, CT scanner. This is a really important and interesting technique. Its use should be discussed case by case. The data sets should be adapted to children to use as low as possible, to lower as low as possible the doses. The use of contrast has also specific indication and should be discussed case by case. There are indications, especially whenever MR imaging is not available, that are trauma, hypertension, tumor, or urolithiasis, for example. Again, our working group has published a recommendation that you can find either on the website or in pediatric radiology for the use of CT in the pediatric urinary tract. MR imaging is a highly praised technique. We like it very much. There are numerous and increasing indications. The technique is more and more standardized, and we know that the problem is accessibility and duration of the examination that render it sometimes problematic. Is it a grail? Yes. In children, MR urography combines advantages of the late intravenous urography and of scintigraphy without ionizing radiation. There is little toxicity of the drugs used. MR urography has a triple role: morphology, excretion study, split renal study, function, and more function analysis in the very next future. This is a very complicated slide. I would surely not detail it, but again, you can read it and find it on the website and published in Pediatric Radiology on how to perform pediatric MR urography. It can be performed at any age. These two examples are in infants. On the left side, you have a right UPJ obstruction, and on the left side, you have a left megaureter, very nicely demonstrated by MR urography. As mentioned, the indication of MR urography are numerous, are increasing. Classically, we would apply it to obstructive uropathies, to complex duplex system, to dysplastic kidney, to cystic kidney, and to acute and chronic pyelonephritis. What about the functional assessment, the contribution of MR urography to functional assessment? It is somewhat controversial, since measurement of signal does not really correspond to function, but still progresses are made. We can already provide information about split function, and the direct functional evaluation will be, I'm convinced, very soon confirmed. And an interesting article has been just published in Radiology in 2014 about the chronic urinary tract obstruction and the evaluation by MR urography. To assess function, or directly or indirectly, we inject contrast, and you acquire multiple successive acquisition every 5 seconds, and this can be assessed by a graph showing the evolution of the signal with time, and this graph has been standardized and show the enhancement of the several parts of the kidney during time, with finally an hypersignal opacifying the renal pelvis. The excretion can also be analyzed and expressed under the form of a graph by evaluating a region of interest. And you can see here 2 different types of graph. Above is a normal one, and on the lower part is an abnormal obstructive kidney. This looks very similar to graphs obtained by scintigraphy. And some team hopes to find correlation between the type of graphs and the type of obstruction or sub-obstruction. The problem and the controversies are the same that with scintigraphy. Finally, renal transit time provides also information about the degree of obstruction or function, indirectly function of the kidney. The time between the hypersignal of the cortex and signal into the ureter can be determined, and according to the number of seconds, you can determine normal, equivocal, or obstructive pattern. Several sequences like MR angiography do provide images, provide very nice images about the renal vasculature. I wouldn't detail isotope, not because it's not an interesting technique, but just because I have no big experience. This is not part of the radiology department where I work, but you should know that to date it is a gold standard technique for evaluating renal function and for evaluating acute and chronic infection in the kidney. But it is rarely performed as an emergency procedure. The second learning objective is to be able to recognize the most frequent congenital malformation, and one concept you should be familiar with is the concept of CACUT, which corresponds to congenital anomalies of the kidney and the urinary tract. It includes a wide spectrum of anomalies, from renal agenesis, multicystic kidney, duplex collecting system, urethral anomalies, and posterior urethral valve. It's quite common, 1 over 500 live births. Most cases are sporadic, but there is a strong genetic contribution. It is the commonest cause of chronic disease in children. Here, a first example of very classical renal malformation, the so-called multicystic dysplastic kidney. It is a unilateral disease. The kidney is non-functioning. You have cysts of various sizes without connection between them, and no renal pelvis is seen. Another typical example is a UPJ obstruction, with more and more and almost always an antenatal detection. You can see on the left side of the slides the dilated renal pelvis on a transverse scan above and on a sagittal scan on the lower part. So this is a way the urinary tract malformation would be detected nowadays and confirmed after birth. An amazing, surprising anomaly is represented here. This is a so-called intra-IVU, and it showed ectopic kidneys in a set of twins. You can see that in both kidneys are in the same side. It is called crossed ectopia. What's amazing is that you have the mirror image in this pair of twins. Another very classical anomaly is represented here. This is a duplex kidney. You have two moieties. On the left side, you have a T1 postgadolinium image with non-functioning upper pole, and you see the functioning lower pole. On the right side of the slide, you have dilatation of both part of the duplex kidney. You have both parts have obstructed UVJ obstruction. This is a test case and correspond to the case of this newborn with an antenatal diagnosis of hydronephrosis, a questionable diagnosis of ureterocele that was seen during the second but not during the third trimester. The delivery occurred a term. The child urinated normally, and here is ultrasound at the third day. You have the left kidney, who was completely normal with a normal corticomedullary differentiation, and you have a dilated right kidney. These are two scans of the bladder, a parasagittal right scan on the left part of the slide, and a transverse scan of the bladder on the right part of the slide. So, what would be the correct statement? This is a case of complicated duplex system. This is a case of right UPJ obstruction. There is an associated adrenal cyst. There is no visible ureterocele. There is a ureterocele associated to a single system. Now, actually, the right answer is this is a case of a complicated duplex system. How do we see this? We see it because we have a dilated kidney here, and one of the answers is that we have an associated adrenal cyst. No, the adrenal is seen here. It's seen, you see the right arrow, the red arrow, excuse me, and it points to a cyst. And you do see the adrenal here, which is outside of the kidney. So the cyst is within the renal parenchyma. We see here this image, this thickening. This is a collapsed ureterocele. The upper pole is not functioning up anymore, and this is why the ureterocele has collapsed. Finally, you did have two ureters, and waiting a little while, you see that you do have a duplex collecting system. So this is a complicated right duplication. The third part of the learning objective were to gain understanding in imaging approach of urinary tract infection. It's very common. Urinary tract infection is very common in children. There are 5% of girls and 0.5% of boys that will be affected. The prevalence is higher in newborn boys and school-age girls. There is a high rate of recurrence, that increases even up to 50% in patients with acute pyelonephritis. The higher the number of infections, the higher the risk of scars. What is the role of imaging? It is to identify patients at risk in order to try to prevent infection, to diagnose urinary tract infection with renal involvement, to identify patients with risk for recurrence, and to diagnose complication. There is no consensus and there is no ideal workup, and as you can see on this slide, in Brussels at Children's Hospital, ultrasound determined the rest of the workup, where in another hospital in Brussels, every child undergoes DMSI scan in case of confirmed urinary tract infection. And in Lille, in France, ultrasound is performed, but only 6 weeks after the infection, unless the child is very ill. So what is a group at risk? The group at risk is a group with CACUT, with congenital anomalies of the kidney of urinary tract, as you can see here in this fetus, who has ascites, a distended bladder, a distended posterior urethra, and this child has a posterior urethral valve, as you can see here, and bilateral reflux. This child is at risk of 5 to 10 urinary tract infection during childhood, so this has to be prevented. Several techniques may contribute to imaging, but no single technique answers to all questions. Cystogram will respond to the question of whether reflux is present or either in any urethral anomaly, while the other techniques will image the renal parenchyma. In the acute stages, and we will focus on the acute stages of the disease, there are 2 main imaging techniques that would be used. These are ultrasound and scintigraphy. Ultrasound is and should be the first-line examination. The first role of ultrasound is to look for underlying uropathy, and for the need for nephrostomy in case of complicated infection and pyelonephrosis. Like here, you have a sagittal scan of the kidney. You see that the urine is echogenic. This is a pyelonephrosis, or in this case, you have lithiasis, you have distended calyces with echogenic material, probably pyelonephrosis, and an interventional procedure must be applied. Whenever you want to evaluate the kidney, you have to analyze them in both kidney at the same time on a transverse scan. It will become obvious to you that the kidney with acute pyelonephritis has an increased volume, which is the main characteristic of acute pyelonephritis. You should compare both kidney. This increased volume can be localized. As you can see it here, you have a bumping of the kidney in the lower part. Other anomalies are represented here with an echogenic hilum. You should know that children have no fat in the hilum, so whenever you see echogenic material, you know you have inflammation. What you also have here is thickened wall of the pelvis, you have pyelitis. These are both signs indicating a risk for acute pyelonephritis. And when you perform follow-up examination, like in this case, you see that this hyperechoic hilum, this thickening of the wall, has disappeared on a control examination 3 months later. So we would look for increased renal volume, but for loss of corticomedullary differentiation, areas of diffuse hyperechogenicity, and whenever you look for abscesses, you should look at the periphery. Also interesting is the contribution of color, a power Doppler. You can see here you have a swollen kidney, hyperechoic hilum, thickened bladder wall, loss of corticomedullary differentiation, and no perfusion on color Doppler. This is a typical appearance of acute pyelonephritis. And as mentioned, whenever you look for abscess, don't forget to look at the periphery. As you can see here, abscesses develop at the periphery of the right kidney. So this is the second test case. This child had high fever, abdominal pain, and raised sedimentation rate. She has normal chest X-ray, normal urine analysis. She was prescribed abdominal ultrasound that was normal. This was obtained as ultrasound of the kidneys. You have the right kidney and the left kidney. So what is the correct answer? Both kidneys appear normal. The left kidney is abnormal. The sagittal view are sufficient to exclude acute pyelonephritis. Both kidneys are abnormal, or transverse scan are helpful. Both are normal, both are abnormal. The left kidney is abnormal. Sagittal view are sufficient, or transverse scan are helpful. The answer is that prone transverse scan are mandatory. As you can see here on this transverse scan, the left kidney is swollen as compared to the right kidney. The differential diagnosis of acute pyelonephritis is cystitis, so you should look for thickening of the bladder wall that can be hypervascularized in case of cystitis. It can be localized, as you have here, pseudotumoral cystitis associated with acute pyelonephritis. There are controversies that are not resolved on who should undergo ultrasound, and probably the best answer to this are children with confirmed urinary tract infection and high fever. DMSA is considered as a gold standard, and it is surely useful. As mentioned, it would not be performed as an acute procedure, but on imaging you can nicely see areas of these defects corresponding to acute pyelonephritis. Again, there is no consensus on the use of the MSA. The two other radiological techniques that can be used for acute pyelonephritis are CT scan, but surely we would not use it for all children. We should use it and optimize it to the children, and especially in cases when the question is either or not an abscess within the kidney. You should obtain late scans, and you can see, like here, areas of unenhancements or heterogeneous enhancement corresponding to the abscess. We surely love MR imaging. It is a highly sensitive technique, and it equals the MSA for the diagnosis of MR imaging. What are we looking for? We are looking for areas of unenhancement, as you can see here in T1 after gadolinium, or here with diffusion-weighted sequences as compared to classical T2 weighted images. The last technique is VCUG, which is present in 30 to 40% of patients. Again, its use is controversial. We think that this should be used in patients with abnormality seen on ultrasound. And again, the contribution of VCUG is to detect reflux or anomaly of the urethra. So I would end with this algorithm, again, in case of urinary tract infection that you can find on the website and in pediatric radiology and produced by our uroradiology working group. So these are the objectives that we had, and we hope that you will be more familiar with imaging techniques in case of imaging the urinary tract. I thank you very much.